Grew up on Mercer Island, and during his high school, he became an All-American swimmer and captain of the men's swim team. His undergraduate degree is from Brown University, where he was elected captain of the men's swim team. He received his medical degree from the University of Pennsylvania School of Medicine. For orthopedic surgery residency, he attended the Hospital for Special Surgery in New York. And during his residency, he also did a mini shoulder fellowship in France with the internationally renowned French shoulder surgeons. Finally, he completed his sports medicine and shoulder fellowship at Rush University. He has advanced training in ligament reconstruction, cartilage regeneration and transplantation, limb realignment surgery, meniscus transplantation. For the elbow, he specializes in the ulnar collateral ligament reconstruction and repair, as well as advanced sports techniques in professional athletes. He also has an extensive shoulder training in shoulder arthroplasty, open and arthroscopic stabilization procedures, and revision rotator cuff techniques. Additionally, he has received a fellowship training in both surgical augmentation as well as non-operative treatment indication for orthobiologics. Please welcome Dr. Garcia.
Is this working? Can you guys hear me? Perfect. This is cool. All right, thanks for having me. So we'll talk about orthobiologics, and then we're going to talk a little bit. We have integrations of how we integrate these biologics sometimes in our surgery as well. Now this is more surgery focused, so you guys have heard about biologics in general, but there will be some most information on how we add this to surgeries to make it better, okay? So, and again, you guys heard my introduction. Thank you. So these are my disclosures. And this is special thanks to Dr. Brian Cole. So most of my biologics training came from Dr. Cole at Rush in Chicago. You guys may know him, he's probably one of the world's leading experts in orthobiologics, as well as leading experts at cartilage restoration. So I had the pleasure of training with him and was able to bring that skill set here to Seattle. So the objectives of this presentation, really going through the overview. PRP, we're going to look at that and its use in musculoskeletal medicine. We're going to review stem cells and their use in orthopedics, review how biologics can help surgical outcomes, and then how we combine surgery and biologics to get the patients the best results. So here's the current landscape in 2019. So you have orthobiologic options. You have something called cytokines and proteins. So hopefully we have enough time at the end to talk about that. It's only going to be a brief few slides. We have PRP, and what's most important is you understand that there's multiple types of PRP, and we'll get into that later. But you have the leukocyte-rich, leukocyte-poor, and then you talk about stem cells, which is the sort of fancy stuff people like to talk about because it's all over the news. But you have autologous. We'll talk more about that because that requires more surgical techniques with marrow and adipose tissue or fat cells. And then you have allogeneic, adipose, marrow, and cord. You guys have heard a lot about the cord because most of the people in the city who advertise for stem cells are doing the cord stuff because that's called renew, or amniotic fluid. So what's the need? Well, osteoarthritis is a big problem. 52 million, you just heard about someone talking about replacements. 52 million in the US are diagnosed with OA, and you have 60% are over 65, so that's a big issue. We do over 1 million joint replacements a year. So can we find a way to reduce that number slightly? I know the other guys might not like that as much, but in my situation, my whole goal is to prevent knee replacements, shoulder replacements, etc. So what's the need? So rotator cuff tears also are an issue. So you have 10 to 30% of patients. 5.7 million people in the US have rotator cuff tears. We do about 270,000 rotator cuff tears a year. I do about 2 to 3 rotator cuff repairs a week easily. So this is a big problem. And here's another issue. Just because you do the repair doesn't mean it's going to do well. 40 to 60% re-tear rate at 1 year by MRI. Now that doesn't mean they're going to need surgery. And I usually quote people about 10 to 15%. But this is even done perfectly, every indication possible. So how can we enhance these repairs so they're not failing? Because the second time and the third time are much worse outcomes. Tendonitis and soft tissue injuries, so 66 million healthcare visits for injury, 4.5 million sports injuries requiring medical attention. So as you can see, there's a pretty broad need for a way to enhance this or reduce the need for any surgical intervention for these types of injuries. So what are orthobiologics? Well, they're substances found naturally in your body that help heal more efficiently. You have matrix materials, which are bone grafts or autologous blood, artificial matrix materials, you have growth factors like PRP, you have BMPs, and then stem cells, mesenchymal, or progenitor. And we'll talk about most of these things in the talk. So what's the problem? Well, I'm not sure if they asked me here for this reason, but to at least talk to you about there's a lot of people out there advertising for stem cells. Stem cell clinics are extremely proliferative in the United States. There's 570 sites that advertise therapies for sports injuries, autism, MS. If you look it up and you have a problem, someone will tell you stem cells will work for it. This is just an example of Chicago where I trained, and you can see that's just a number. Those are just the major stem cell clinics. Those aren't affiliated with any type of academic institution. They're mom and pop shops that charge $10,000 for stem cells, and they're clinics that offer all this stuff with direct marketing to consumers. Their language is intentionally imprecise and exploits the vulnerability of patients with debilitating diseases. And the US, not surprisingly, has the world's highest density of online stem cell tourism in the world. I spend, being the biologics guy in my group, I spend a large amount of my time with patients that come in about biologics to try to convince them not to spend that much money on stem cells, or not even to get stem cells alone. So this becomes a real problem even for someone like me who takes care of patients like this, because most of the time I want to offer them a cortisone or even maybe consider a PRP, but not even going down this line. So it's just something to think about. Google hits 2017. It's a lot. 20 million articles on PRP, 94 million on stem cells. So you can see the financial gain changes things a little bit when people start looking up Google. So here's a problem. We got to divulge what's right information and what's incorrect. PubMed articles is our main source for good overall research. You can see the PRP exponentially increased, as well as stem cell articles from 1990 to 2016. So what's marketed to us surgeons? Well, you can see here's a number of things. This is from 2018. ANA is our second or third largest sports meeting in the world. And you can see all the different types of implantations we use, and you can see what sort of in-house data or peer-reviewed articles. There's not that many. Novacart, Neocart, lipogyms. So we'll talk about lipogyms. That's sort of the fat. When you take fat, spin it down, that's fat cells. And you have all these other options. Renew's right here, the injection says multiple anti-inflammatory or other healing factors found in amniotic tissues. But again, there's limited articles, 1, 2 peer-reviewed. So this is again from that same article. You can see here, look how quickly, now again, this is not all data, this is just what we call good quality data. Look at how precipitously these other options drop off with no data. And you'll see a lot of these advertised for. The red is what I do in my practice. So overall, I spend a lot of my time, I do MACI, and MACI and ACI are very similar. MACI is just the newer generation, so that's why you gotta kind of clump those together. Fresh angiochondral allograft, we'll talk about that briefly. PRP, I do a number of those as well. And then the osteochondral allograft transplantation, so fresh from the patient's cells. So what's the rationale behind these biologics? Well, there's anabolic and anti-catabolic molecules that modify the arthritic process. So arthritis is obviously the big one we always think about, that most patients can see in practice for arthritis. And then the regenerative process, so finding a way to regenerate or find a way to preserve cartilage, synovium, stimulate these mesenchymal stem cells, and then stimulate subchondral bone. So here's it. I'm glad the video is playing. Okay, so look at this. So this is a patient. You can see this is like a 32-year-old patient. This is a cartilage defect that they have. All right, it's a bad problem. That's going to be removed. So what do you do with that? So we have this. You have this fresh allograft. So within 24 hours, 24 days deceased. We core out a plug. We use something called bone marrow aspirate, and we'll talk about that a little bit. And that enhances the healing. So we soak that into bone marrow. There's other ways of doing that with a putty. And then we actually implant it into the patient's knee right there to preserve their cartilage. It's got some impressive results, but this is a pretty cool video. We'll play. Let's see. I might not get it to play. Oh, it's on a little load. Anyhow, plug's completely integrated. Again, the data on this is around 85% return to sport and success, so we're pretty happy with our results. I usually do bone marrow, but we also consider PRP in some cases as well. So here are the options. Okay, so I don't really, corticosteroids and hyaluronic acid aren't really options, but when patients come in, this has to be part of the discussion. If they haven't tried these, I'm not going to start offering PRP or other more expensive options that insurance doesn't cover. And so we'll briefly touch on those first two. So steroids, we all know about them. All your friends may have had a cortisone injection. Orthopedic surgeons do a lot of corticosteroid injections. So it's good for a problem, but it really is a short-term relief. And there was a recent article that came out that showed that actually can hurt overall cartilage. We'll mention that just briefly. So it's not something you just willy-nilly want to give someone an injection of. Again, this is our JAOS, one of our big journals that we have, a summary, finding that on average it gets about 1 to 2 weeks of relief. So that's not really that successful in someone who's got bad arthritis. Again, is there a downside? So this is JAMA. Obviously, you guys know that's good, a very good quality article. Randomized control trial. So steroids every 3 months for 24 months. This is grades 3, 4. These aren't bone on bone. Okay, that's important. MRI cartilage loss. Now, MRI can over-accentuate things, but it's important to understand it. Was around 0.21 millimeters loss versus saline, which is 0.1. So it's not much, but again, at 2 years, there was a significant loss of cartilage in the treatment group with no significant difference in knee pain. So we're giving people cortisone, we're progressing their arthritis and maybe needs a knee replacement earlier. Now obviously take this with a grain of salt, but it's just something to show you that maybe we shouldn't be injecting cortisone all the time in patients. Viscosupplementation. Okay, so you guys may have heard about this. It's called hyaluronic acid. Maybe you've heard Rooster shots. Maybe you've heard Synvisc. All these different types of the same type of thing. It's hyaluronic acid. So this is from the AAOS, the Academy of Orthopedic Surgeons, strongly recommending against the use of hyaluronic acid. And you ask why? Well, as a result of this, the very frustrating part of our practice is that about 2 years ago, we used to give these out. We'd given patients. I've had a number of patients. There's a lot of good data on this. And all of a sudden, insurance companies got this and stopped paying for all of it. So now you have patients that come in with arthritis. The only option I have for them is steroids. Everything else has to be paid for out of pocket. Some insurance companies are still paying for it, but it's much more difficult. They can't come in the same day and get it. They have to get pre-authorization, etc. So it's quite frustrating for the patient experience, and mainly because of this article. The problem they have is they had so many different contributions and contributing factors that they didn't exclude or look at, and they made this very strong statement that really hurt the patients themselves. And then another article basically discussing this and saying, did they really miss the mark? And the answer is, I think they did. And here's a JBJS, so it's one of our top journals. Closer looking at the evidence of supplementation favors clinically important reductions in pain among higher molecular weight and cross-inflammations, and is a safe option for patients with knee arthritis. So really, this never should have taken off insurance claims, and is a really good option to try to prevent things, because the next option after this is really PRP, which does have a cost. So now we're going to talk about the fun stuff. People want to talk about PRP. So what is it? Why is it important? So PRP has these things called platelet activation, releases these factors, and again, these growth factors, when activated, target certain areas of the body. So you can see here, PGF as cell growth, new generation repair of blood vessels. You have VEGF, which growth in new generation of endothelial cells. TGF-beta, EGF, and then fibroblastic growth factors of tissue repair, cell growth. This is important. It actually makes hyaluronic acid, so you're actually getting some of the hyaluronic acid when you do PRP as well. So importance, well, there's multiple applications. So these alpha granules in the platelets, they contain various growth factors and cytokines with concentrations equal to platelets. They increase anabolic cytokine activity, again, those different growth factors, including insulin growth factor as well. And these different things have effects on the tissues. So this is important to understand. There are multiple system preparations. Whenever there's a product that has financial gain, there's going to be a different number of people that want to talk about all the different ways they can sell you their products better. So there's over 80 PRP machines on the market, different types. Each system differs in time and centrifuge, as well as the number of cycles, and differ in the different platelet type, white blood cells, and growth factors. So it's important for you to understand this because patients don't understand that. And all the research studies, a lot of the studies you'll see, they have all different types of, there's never really a benchmark to how they're preparing the PRP. Now, in general in this area, most people use a machine called, by Arthrex, that's what we use, ACP, and it's actually a pretty good standard of care, and it's one I've used across the United States, so that's a pretty good one. But in general, there's a number of different ones they can market, and each one has a different supplementation it comes out with. And again, be careful, they're not all the same. You can see up here, these are the different formulas. Different levels of platelets, different levels of leukocytes or white blood cells, a different level of red blood cells. This is from every single different type of spin on the machine. So look how variable that is. So what do the spin types mean? Well, there's PRP, there's single spin and double spin. Okay, so the single spin, okay, we're going to talk about this. This is the leukocyte poor. All right, so this is mostly arthritis, and we'll mention that, versus leukocyte rich, which is the double spin. So it's less platelets, fewer white blood cells. It's called the centrifuge ACP. It's faster and cheaper, so that's important to understand. Because patients that should get the other one are getting this one because it's cheaper for the doctors to give it to them. So I have both machines in my office. I have this one, and then I have this machine too. So when I need to give them a certain type of PRP for arthritis, I give them that. And when I need to give them one for tendons, I give them the different type. But I just had a lady who had a hamstring done, supposed to be done with the leukocyte rich, based off all the studies we'll talk about, and got poor, so clearly there was really no one really actually knew what was going on when they gave it to her. And so it's important for you to understand that there's a difference, and that you need both machines. Now you can do the poor with the rich, but these kits are more expensive, so most people will not give a patient with leukocyte poor from this machine. So that's something to understand about why people are getting what they're getting, and there's a reason behind it. So what is this poor rich thing? This is confusing, explain it. So we have leukocyte poor PRP. It has a reasonable amount of platelets, but very low white blood cells, and that's what you want when you have someone with arthritis. You don't want to cause a lot of inflammation and make their knee more painful. Meanwhile, there's pure PRP, which we're not going to talk about as much today, and then leukocyte rich. So this is important. It's got a lot of platelets. Okay, a lot more platelets than a leukocyte poor, but it has a lot of white blood cells. And so as a result, you want this for healing potential. So tendons, things like that are much more important. But you want to stimulate a response. A lot of patients will tell you they get some inflammatory response after a PRP injection, but it depends on which one they're getting. So patients that usually get the tendon one, this is quite painful to get the injection with a PRP leukocyte rich, but it also has better results in certain different things, which we'll show. So what are the effects on the human synovial side, so human articular cartilage? So you can see again, we're going to talk about rich and poor, so hopefully you guys better understand it by the end. But leukocyte poor has mostly anti-inflammatory properties. Leukocyte rich has mostly inflammatory properties based off these things. Sorry, the coloring's off. So that's important for you to understand. So what are its effects on tendon tissue? So it increases the PGF and TGF beta, which are areas that are essential to healing. It increases the VEGF, so it increases vascularity at the injury site. And then it acts to enhance the tenocyte proliferation. So in vitro, we assume earlier healing, superior quality of healed tendon, and better organization of fibroblasts and collagen. So what's the basic science behind this? Again, we're not going to go through all the articles here, but you can see the summary from this is it's reduced inflammation, you get these myoblasts differentiate, they proliferate, they build their diameter gets larger, and they shorten recovery time. So look at the proliferation. ACP is that one I told you about, the leukocyte poor, but you can see how much faster that increases the myocyte proliferation versus the control and the negative themselves. So we're going to talk about more of the fun stuff, which is the clinical aspect. So PRP and muscle injury. Again, literature suggests that PRP may result in earlier return to sport for acute grade 1-2 muscle strains. Now again, take this with a caveat. These injections can cost patients anywhere from $800 to $1,200. So it depends on the person that you're offering this to, because whether it's statistically significant or not does not matter. Now, if a person's a professional athlete, you get it back 2 games longer and they have a $10 million contract, there's a big difference there. If a patient's like, I want to play hockey for 6 months, there might not be a difference even if you see this. So it's something that I always talk to the patients about. The financial part does matter to people, and it should be part of the consideration. So again, this is looking at PRP. Now again, you want to start comparing it to different things. So compared to saline, compared to gel shots, etc. So this is looking at PRP versus saline. 15 per group, okay, so small cohort, 3 weekly injections. We're going to talk about the type of injections and number. Improvement at 12 months, 78% were improved with the PRP versus only 7% in saline, so essentially the placebo. And you can see PRP's effect really starts kicking in around the 2-week or so mark. I tell patients the PRP takes around 4 weeks when they start feeling effect. So here's hyaluronic acid, so gel shots versus PRP. Double-blind, randomized controlled trial, 50 and 50, so we're getting better numbers. Again, you can see here, PRP's on the top. You want it to be higher with these type of scores. And you can see PRP really kicks in around the 4-week mark, which is what we expect. And at 6 and 12 months, which is really more important for the patients because no one wants to pay for this or have this done to them and only get 4 or 8 weeks of relief, they're seeing statistically significant improvements. And also VAS scores, so that's how much pain they're in. These are all done under ultrasound, so that's a difference of opinion of how you want to do it, and difference of opinion if you feel comfortable doing it with regular versus ultrasound. So again, talk about this rich versus poor. So we kind of opened this up already. So you can see here, here's a really good, this is a meta-analysis and a systematic review of this, looking at treatment for arthritis. Okay, this is mainly arthritis we're focusing on now. So leukocyte poor is significantly better than gel shots, PRP, or placebo. And this is comparing, you can see the studies down here. HA is the gel shots, placebo, and then here's one where they actually compared leukocyte rich versus poor. Sorry, there's a little blocking the way. But you can see, and again, leukocyte poor is the majority of the comparisons they're using. So how about a combo? It does make this more confusing. So if you actually add the two together, it can have a synergistic effect, and there's some studies that show that. Where I trained in Rush, the number one combo, obviously there's finances are always a part of the discussion, was 3 hyaluronic and 3 PRP at the same time. Most of the guys in the city are doing usually 3 PRP at a time, and may or may not be adding the hyaluronic acid, but the studies show that the combo is more effective. Again, though, it's just more volume and then obviously more cost by adding, that's 6 total injections you have to pay for. And if it's not covered by insurance, that can be quite frustrating. So PRP versus HA again, this is treatment for, so early versus late, this is really important. Non-randomized, okay, so that's something negative, I guess. PRP, 50 people with 3 injections at a time versus hyaluronic acid. At 2 months and 6 months, the PRP was significantly better than the hyaluronic acid. But again, it worsened with age and it worsened with severity. So you've seen those pictures maybe on the news where someone shows like a patient has no joint space left and they like got better by stem cells, and then everyone tries to go to that clinic to make themselves better. Again, I don't do this for patients that have grade 4 arthritis. These are patients generally that tell me, okay, I can run 2 or 3 miles, starts to swell up on me. Their arthritis is maybe moderate, so grade 2, maybe grade 3. And these are the patients that will really benefit. The ones that already have a stuck knee, or they can't extend their knee, or they're complaining of a ton of pain, they can barely walk, they're not going to get better with PRP. So your selection is important. You want to have happy patients. So how about the number of injections? So you keep hearing this 3 number. So again, here's a guinea pig study. This is pretty new out of AJSM, showing 36 pigs. There's 3 treatment arms. So they gave them control, which was nothing. One is 1 PRP injection, and 1 is 3 PRP injections. And you can see at 3 months, both the 1 and 3 did well, but at 6 months, the 3 combo was much better. So the longevity lasts by adding those 2 extra injections, and that's what the thought process behind that. And you can see here, that's what the scores are. So you can see you want a low articular score. So the G2 at 3 months and G1 are very similar, but then here you can see it still stays the same level, but the other 2 start coming up similar to the controls. So this is a really brief summary. I'm sorry it's a little blurry, but this is from Anna. Again, Dr. Dragoo is quite an expert at this as well from San Francisco. But PRP outcomes for OA. So again, look at the box over here. I tried to highlight it for you. You can say significant difference for 4 out of the 6. Now the problem is, look at the 2 there. One is double spin leukocyte rich. We talked about that not being a good option. So clearly that they missed the boat on doing that. But again, this is a little bit older study. In 2012, again, leukocyte rich did worse. So you can see here, it matters what you get. And if the number of people that come into my office and say, oh, my doctor told me about PRP, and they wanted to give it to me, but I read your stuff and I want to come see you to talk more about it. And I'm like, well, they tell you about the 2 types. And they're like, no, I don't think that they know what's going on there. And that's important to understand that, because if someone starts giving them leukocyte poor, they're not going to do well, and they're going to spend that money on a PRP injection. It's not going to be effective. So PRP and lateral epicondylitis. So here are some studies here. Again, this is something that I still offer patients. So you have this one from 2013. It's equal effectiveness to controls. So there's one study where it's not as good. Then it's equivalent or better at 6 months. So it takes a little while for this to sort of be the advanced option. This is 2014, 2011, better DASH scores and VAS scores. Now again, this is compared to glucose injections, not to steroids. And then PRP, better DASH scores at 1 year. So you can see the longevity is there, 1 to 2 years. This is the same. This is a study that just came out literally last 3 weeks ago, so I thought I'd put it here for you guys so you can see it. This is an outline again of those studies, adding a couple more. You can see here now, what's interesting about the first study is they compared PRP to actually surgery, which I think is really not a fair comparison because that's usually the end result. So obviously PRP did not do as well as surgery in that option. I would never compare those 2 for patients, but this one here, you can see almost all of them except for maybe the bottom one. There's 2 out of the 4 here, again, that were statistically significant improvements in pain scores. And those were actually compared to lidocaine and corticosteroids, so that's a good one too. So we've compared it to glucose, which is placebo, and we compared it to corticosteroids, and in most cases, it has a benefit. How about patellar tendonitis? So these are the 3 studies you can see here. Dragoo again, 2014, 23 participants. So these aren't very large studies, unfortunately, and better at 12 weeks and equal at 26. So it did burn out after a certain period of time. This one is 28 people at 2012, 3-month follow-up. Almost all of them are back to sport. Now, patellar tendonitis, when it gets to this point, is very frustrating. I mean, these patients are basically 1 step away from needing surgery because they can't do anything. So that's actually pretty good. They're only at 21 out of 28 back. And in my practice, I've had about, I would say, I'm about 75 to 80% success with the PRP. Now again, they've tried steroids, they've tried a ton of rehab, and they finally come to me. So of those patients, I think maybe one or two or maybe a handful eventually need debridement. All right, so let's talk about rotator cuff repair. So rotator cuff repair, PRP doesn't work very well for. So you can see here, these are big, big studies. You know, we have 1,100 people on that one, 900 in the others. There's two that I marked here. They wrote there was some better pain scores, but no better healing in all of these studies. And that's important to understand because the pain part is important. Obviously, you don't want patients to be in pain, but after 6 months, 6 weeks, majority of patients have minimal pain. So is it really worth that injection to do it for them? And then also the question is, when did you do the injection? Did you do it right after the surgery? Well, or during the surgery? Because if you do it during the surgery, and you inject them, and you have fluid still in there from the arthroscopy, is it actually even going in? So there's some questions to always talk about with the methods here. So in general, I would not recommend PRP for any type of rotator cuff issues. How about UCL? So you guys have heard about this with baseball players. This is the Tommy John ligament. So here's 3 studies. Again, Dines of the two. So look at this again. Remember, it's a ligament. So it's a ligament or a tendon. So it should be done with Rich. So you have the first one deal, really good results. Okay, 91% because these players, they have tears. If they can't get back to throwing, they're getting a reconstruction, or they're getting something that we now do as a repair, but they're getting surgery. So to offer a PRP option, hopefully avoid these players from having to need surgery is a big deal. And they're in the college or professional level, it's even a bigger deal. No college player, no professional player is going to make it with a partial tear is going to make it to surgery without trying a PRP injection first. Dines, now he didn't have as good results, but he had a pretty low study, only 6 patients. And again, he used leukocyte pores, so that's really not as good of a comparison. And then Podesta here had really good results, 88% return to sports. Those are quite good. So in my baseball players, high school or above pitchers, I will offer them PRP as an option if they fail to return therapy. And I will not do a cortisone injection because I do not want to damage that ligament anymore in this type of situation. So PRP and glute medius tears. So 80 patients. Okay, again, they compared steroids, ultrasound guided versus PRP. Leukocyte rich. Grade 1-2 tendinopathy. These aren't complete tears. The steroids maxed out at 6 weeks, which is about what I'm talking about. And as you can see here, the PRP was continuing to be statistically significant throughout the rest of the next 52 weeks, almost 2 years. They followed these patients. So it's interesting. It's actually interesting. This study came out, and like 2 weeks after it, I had one guy come to my office actually with this, and he had been suffering for this is anecdotal, but he was suffering for 3 or 4 months. And we gave him the PRP injection. It was amazing that literally in 4 or 5 weeks, he was made significant improvement. Because he's also one of my scheduler's best friends, so I was really happy about that. Okay, so here's one. I'll try to explain this slide. It's a little bit confusing, but a lot of patients, okay, so people always ask, can I get a PRP injection to get my meniscus fixed? Well, not really. It doesn't work like that. It's a synergistic effect. So you can see here, let's explain this better. When you have an ACL tear and you do a meniscus repair, the data shows it's a significantly improved repair quality because you have all that blood from the ACL going in, and therefore there's stem cells and et cetera, and it heals better. Now, they found when you add PRP and ACL with a meniscus repair, there's no benefit. But if the patients had a meniscus repair and PRP without the ACL, they had a significant improvement from overall. So we say about I tell patients 70% success with meniscus repairs in isolation. And you can see that by it says the PRP with no ACL, that's the large dark line at the top, which is pretty impressive, that's PRP. With no PRP, you can see it drop off significantly to almost about a 12 to 15% improvement with the PRP. So that's an impressive article. I was happy to see this. I'm still not offering this in my practice because the only negative about this is there's something called microfracturing of the notch where you stimulate it, and they didn't look at this, but it's just something to show you. So hamstring tears, people come in and have hamstring pulled, etc. Now this I think relates more to the professional athletes because return to play was only about 20 days or so better with the PRP, and pain was better. Now I'll still try PRP for someone who's failed everything else before surgery because these are partial tears or small tears, not ones that need to be fixed surgically. So the last thing I want to do is offer them a surgery if I think I have even a shot of making it better with the PRP. But definitely this makes sense. I mean, you don't know any of those professional athletes that are getting PRP. I mean, the linebacker for the Seahawks does it as a routine before the year starts. It's sort of a flush out, which I wouldn't recommend always, but this is just something to think about. Okay, so that's enough of PRP. Now, here's talk about this. We'll hopefully everybody's not put to sleep yet. We'll do some fun stuff briefly, and then we'll try to jump on. How are we doing with time? Okay, we'll go quickly. All right, so again, this is how I decide and all the other options, okay? So, debridement, first line for in-season athletes, okay? You don't want to do anything fancy with them. If they can just get it cleaned up and get them back on the field if possible, without hoping they're not going to do too much damage. Microfracture, again, those are poking holes in the bone, generally very small defects. Something called biocartilage we'll talk about, that's for moderate-sized defects. And then osteochondral allograft transplantation, that's their own cartilage, those little plugs over there. Those are for high-demand athletes for smaller defects. MACI is something where we take the cartilage, biopsy it, grow it in the lab, and stick it on like glue on the sheet. You can see that right there where it's sutured, and that grows in. Mostly you do that for patella or trochlear defects. And then for the condyle, it's usually osteochondral allograft, which is generally the go-to. And even since this slide was made a year or two ago, it's coming even more aggressive that we sort of go down to that line because the data is so good on those. So biocartilage, what is it? It's like microfracture plus. So you've heard of microfracture? Well, we add this to the microfracture and it brings the rates up from like 65% to 80% healing. So I generally won't even do microfracture. I'll only offer this option with the microfracture because the data is so much better. And again, here you can see the model here with Brian Coles on this one. Repair scores. You see when you add microfracture, right there, you see the improvement. I mean, when you add biocartilage, you see the improvement over there, and here's the histology on that. So how about MACI? So this is the one I told you about. We grow it in the lab, have a sheet of cartilage pasted on there. Again, these are difficult situations. This is patella defects and defects of the trochlea. The groove, you can see 73%, again, better than microfracture. Microfracture deteriorates at 2 years, and ACI or MACI still continues on. How about osteochondral transplants? Those big cartilage plugs I showed you earlier. 75 to 80%, 88% return to sport. We're talking about 85% at 10 years, which is pretty impressive. These are big problems to have, and they'll continue to chew up the meniscus, chew up the cartilage below if you don't take care of these mechanical issues or the pain. So these are really satisfying patients. Again, it's a long haul, 7-8 month recovery on this type of surgery. How about, is there an indication? Well, there isn't really. Obviously, we push the envelope. It's a young patient, I'll do bigger plugs. Older patients, above 50 years old, will probably start thinking about doing a knee replacement because is it really worth the 7-8 month recovery? It's a lot bigger toll on the body also when you do these. And again, there isn't really an age cutoff either. Mine's actually 50 with newer data that's coming out, but it depends on the patient. Isolated cartilage, otherwise there's certain factors that have to go into play. Generally under 40 is pretty much I'll try as much as possible to preserve the joint. So stem cells. So there's a number of different types listed here. And how do we think they work traditionally? Well, there's these 3 different, endodermal, mesodermal, and again, they differentiate, and hopefully you can put them in, and then they'll regrow all your cartilage. At least that's what they say on the internet. So contemporary thinking is it's not true, but they really do. These stems, we can't give those stem cells because those don't exist, at least in our ability right now. So we modulate the local environment, decrease inflammation, recruit other stem cells, and release growth factor. Essentially, it's like a really potent anti-inflammatory. So there's bone marrow and adipose, we'll talk about today very briefly. And again, we don't have time to go through the whole video, but that's how we take it from the bone marrow. And there's 2 different, you can do surgical delivery or you can do intra-articularly injections. So again, this is its effects on cartilage defects and OA. So those are the 2 main things that it's been looked at and really it's shown some improvement in. So you can see marrow cells right here, improved clinical outcomes, improved MOCARD scores. That's with taking bone marrow aspirate. This is adipose tissue. It's actually like a liposuction. You stick a large needle in someone's stomach. It doesn't sound very fun. And then you actually remove the fat, shake it up, and then inject it back in the knee. Yeah. That's why a surgeon has to do it. And I've done it a number of times. Every time I do it, it freaks me out. So, but it has good scores on WOMAC, decreased defect size overall, and increased cartilage. Again, almost all these studies, it's a surgery with this. So it's always hard to tell exactly what the benefit is. But look what you have to do. I mean, this patient's on the table. We have to do the little liposuction on their knee, on their stomach, and then inject this fat back in. Again, there is some data. This is more European studies. Increased prostaglandin synthesis. This is level 4 data that shows that, so it's not the greatest data, it shows some improvement overall. I did this in my fellowship. I don't do these lipogens now. I don't think it's really a benefit. I do bone marrow if I need to for cartilage stuff, but for high-level athletes, etc. So I lean towards bone marrow aspirate. These are the different devices. Again, a lot of devices to do this. The Angel's nice, which is the Arthrex one, because it can do PRP and bone marrow, and it can do all three types. So it's sort of a one-size-fits-all option. So we use that one, and most people use the Arthrex one. So where do you go? Okay, well, we just talked about stem cells. So what do we do? Well, you have three options. You can take it from the tibia. So if you're working on the knee, you can take it right here. If you're working on the shoulder, you can take it from here. But the gold standard is iliac crest. It's just scary because someone's putting a needle right into the pelvis, and we're not pelvis doctors. We're sports doctors that are taking it, or people are taking it and are not as comfortable with it. So you have to have a lot of experience doing this to feel comfortable doing this type of trocar, especially because it's just percutaneous like that. But generally, any professional athlete always do an iliac crest. You know, in general, it depends on the patient. I'll talk to them about it because they might not want another poke down here. The best stem cells, the best biologics are from the iliac crest. So again, here's some very brief data we'll go over. But these are condylar injuries, so there's encouraging data that shows it is some improvement. Again, these are focal cartilage defects, so they're different. So again, some improvement, but again, they're all in combination with other things. So these people have alignment issues, other things. So they have all these really fancy surgeries we don't have time to talk about. And this is, again, cartilage defects, so there's 8 studies. So overall, though, there's still a paucity of high-quality literature. So bone marrow aspirate's safe, as long as you know what you're doing with the harvest, but recommend judicious use until better evidence exists. So really, I try not to do as much as possible. I'm a PRP guy, I do most of that. The cost is much less to patients too, especially when they've run out of options from cortisone or hyaluronic acids. So adipose tissue, which is the fat, versus bone marrow. Again, there's not really a clear winner, but the more effective hematopoietic stem cells, I think, makes a difference, and that's why I lean towards bone marrow. Really briefly, just rotator cuff. So this is Hernigo. So anytime Hernigo puts a study out, there's always strong significance. He's, I can't remember where he's from, but somewhere in Europe, but he always has impressive data. So just take that with a grain of salt. But patients without tears have almost 3 times as many stem cells as those with tears. So you can see the difference. So he found that if he had bone marrow aspirate combined with his rotator cuff repair, that he had significantly improved healing, 87% versus 44% at 10 years. So that's good data, that's impressive. Again, he didn't publish in the top journals, so always the question is, you know, why was this not accepted to the higher level stuff? But it's just something to think about. So in conclusion, you know, you have this, and we have time, we have orthokines after this, but we just have fun if we have time. I think we're running over. So, anyhow, here's basically, I do PRP leukocyte core for OA, bone marrow aspirate, occasionally, maybe higher level athletes where like one game sooner makes a difference. And then for rotator cuffs, again, there's not a lot of data on rotator cuffs, and I would not recommend it for that situation, and you've talked about the other stuff. And this is a pocket guideline, no one's gonna have time to read through all this stuff, but exercise increases PRP levels. And there you go.